All right, hello. Today we're going to go through stroke education and orientation, Javon Bay Hospital, Riverside. Today we're going to go through A&P review, what is stroke. We'll talk about TIAs, ischemic and hemorrhagic strokes, the signs and symptoms of them, the imaging that's performed and what that looks like, and how we treat these patients. We'll also go through code strokes, what that looks like, the rules, expectations, documentation that's needed, and the goals. And then we'll review GFAST, which is a large vessel occlusion screening tool. And we'll talk a little bit about stroke mimics. The reason why I want to talk about stroke mimics is because, 20% of code strokes that are called actually end up being a stroke mimic. So first and foremost, I just want to point out that we'd rather cast a larger net and catch the patients that end up possibly being a stroke and then, it ends up being not a stroke, than it would for a nurse to be concerned about calling a code stroke and hold off on it. So we'll go through some items that, look like stroke but end up not being that. So before I get into that, I do want to point out that we have resources. So any newer nurses or, if you haven't cared for a stroke patient in a while, what are your resources for stroke care for these patients? So first and foremost, we actually follow the American Heart Association guidelines. That drives our care for the patients. Their recommendations guide our care. Next, we have our unit stroke book. So each unit has a stroke book available to it with most recent paperwork and references that are needed. So go ahead and become familiar with the unit stroke book. Next is the charge nurse. The charge nurse is definitely a useful person in the stroke team. They are going to know what to do or what the expectations are to care for a stroke patient. The stroke team, Dr. Banzel, Sarah Linder, Dr. Khan, myself, I'm Alicia. If you ever have any questions, feel free to get a hold of us. So on here, I've put my cell phone number and my office number as well as my email. I don't care if it's after hours, on the evenings, on the weekends. If you have a question about the care you're providing to a stroke patient, I want you to feel free to go ahead and text me or call me. That's what I'm here for. I'm here for your resource. So don't hesitate to get a hold of me if you have any questions. Okay, so this is going over the corrective action plan by DNV that was identified in July of 2023. So this is the 2023 to 2024 corrective action plan items that we have been focused on for the past year. Our next DNV survey looks like it's going to be towards the end of June 2024. So the corrective action plans that we have been focusing on and need to continue to focus on, not just because it's a corrective action plan, but because it's best practice, would be our neuro checks. We need to make sure that we are completing the neuro checks as required, either A, by the TPA or tenecteplase thrombolytic therapy protocol sheet, B, in the post-angiogram world, or C, as ordered by the physician. So in here for our neuro checks, so full neuro checks are required when we give tenecteplase and alteplase. A full neuro check in the ED is a full NIHSS within 60 minutes of arrival. If we're giving tenecteplase, we have to have a full NIHSS within 15 minutes before we give the medication. And then again at the time we deliver the medication. And then from there, we can go into the 15-minute neuro checks, which are defined as the modified NIHSS. So just to be clear, in the ED, cognitive assessment and Glasgow Coma score by itself do not count for a neuro check, whether it's a TPA patient or whether it's just a code stroke patient in with neuro check orders. So it needs to be the modified NIHSS. In ED, the code stroke protocol for hemorrhagic or ischemic patients, like any code stroke patient coming in, there's going to be an order placed for Q1 hour neuro checks, and that needs to be followed through until a different order is placed. Again, in the ED, that order check needs to be either the full NIHSS or the modified NIHSS. Oftentimes in ICU, we see this being placed as a Q1 hour order as well. Maybe a little bit different from that, but normally I see Q1 hour, Q2 hour. Step-down ICU has a tendency to be about a Q2 hour check, may differ depending on patients. And then the cardiac telemetry unit, 5 West, that tends to be a Q4 hour check. Again, clarification, everybody. Your neuro check is your modified NIHSS. And then again, with your post-angiogram patients, this starts in CVI. The neuro checks need to be completed every 15 minutes times 4, every 30 minutes times 2, and every hour times 4. Please follow the written physician order. If the doctor puts in an order for Q1 hour neuro checks, that's what we are held to. If the provider is giving a verbal order to change the neuro checks to Q2 hours or Q4 hours, and that order is not entered, then we are still held to the Q1 hour neuro checks, and therefore we will fall out if they're not completed. So please don't disregard any written neuro check orders for a physician's note. If the physician note says Q4 hours and the written order says Q2, we have to complete the Q2 hour neuro checks. Writing a nursing communication order for changed neuro frequency checks does not work, and the reason why is because it gets lost in the orders. So if we place a nursing communication order where it states, okay for Q4 hour neuro checks, but there's still another order in that says neuro checks Q2 hours, it creates confusion for the staff. It creates confusion as to what we are supposed to be doing for that patient. So please, if that neuro check needs to be modified, please make sure you're actually modifying the neuro check order itself. Also, what's written is what we're expected to document. We are held to the orders that are placed. One of the other corrective action plan items from 2023 to 2024 was to have a comprehensive stroke center transfer agreement with a close comprehensive stroke center. So we have obtained a transfer agreement with OSF St. Anthony's. So if we were ever on stroke diversion, then we would transfer the patient to the nearest thrombectomy capable hospital. Post-angiogram checks, whether the patient had a procedure via femoral artery or radial artery, we need to make sure that our post-angiogram checks are documented as required by the protocol. So for TR band, we need to make sure we're documenting the amount that we're inflating the TR band. And then we need to make sure that we're deflating it by 3 milliliters every 30 minutes. And that we're doing Q15-minute checks, and we're documenting that during deflation and continuing on after we have full deflation. Each check for post-angio has to be a pulse of the extremity, right? That's your CMS check, your blood pressure, and your puncture site. So pulse, pressure, puncture site. All of those, plus your vitals, need to be in at the same time. Once we hit full deflation, then your checks move to Q15 times 4, Q30 times 2, and Q1 hour times 4, making sure that we are documenting the neuro checks as ordered. In your post-angiogram tab, it's a flow sheet. You actually can use that tab to kind of condense all the items together that's needed to be documented. Makes it a little bit easier for you. Okay, I do want to go through some core measures so everyone's on the same page. Your NIHSS, whether the patient comes in through the ED or whether they're transferred from an outside hospital, a full NIHSS has to be done as the first check, and it has to be done within 60 minutes of that patient arriving. Whether it's TIA, ischemic, or hemorrhagic patient, that full NIHSS must be completed as the first neuro check and within 60 minutes of arrival. Other than that, for ischemic and TIA patients, the following neurochecks, the following like NIHSS would be required at 24 hours, give or take 20 minutes, and then again at either discharge day or day 5, whichever one comes first. Clarifying that because if patients stay on up to day 7, you do not need to do another NIHSS at day 7. Also remember that day of arrival is day 1. So if the patient comes in, that's day 1. It's not 0 and then post-op day 1 for the next day. So if they come in on the 4th is day 1. So day 5 would be the 8th. Just wanted to clarify that because sometimes there's some confusion in that. Dysphagia screening, we really need to focus in on this. So we use the Barnes-Jewish Hospital dysphagia screen. You can see what it looks like in the flow sheets here. There are 2 sections to this test. The first section is entering yes or no based on the patient assessment. So the first one is Glasgow Coma Score. What is it, right? The cutoff is 13. So being that we're documenting whether or not the Glasgow Coma Score is less than 13, we need to make sure that we have the Glasgow Coma Score actually documented in that, right? So make sure your Glasgow Coma Score is documented, and then you would answer whether or not it's less than 13. Next, you move on to facial weakness or facial asymmetry. For that, you would just have that patient smile, and what you're looking for is asymmetry of that smile, that nasolabial fold. When they smile, if they have a weakness in that facial muscle, we're already saying yes to that. We're answering yes, and the patient automatically fails. What happens if the patient has a facial droop from a previous stroke, and now they're coming in with more stroke symptoms? The answer is you would fail that patient. What happens if the patient says they have a baseline crooked smile and now they're coming in for stroke? You would fail that patient. If the patient has facial asymmetry or facial weakness, you have to fail that patient until speech evaluates them. The purpose of this test is to look at the muscles that it takes to help swallow, and that assessment can help us determine ahead of time whether that patient's at a higher risk for aspiration. So the worst thing we could do is say, yes, these muscles are affected, and I'm going to still continue on to give them the water test. Next, you would assess the tongue. You have them stick their tongue out. If their tongue sticks straight out, fine. If their tongue, when they stick it out, if it leans to one side or the other, that would be tongue asymmetry or tongue weakness. If either of that's present, you would say yes, and you would stop the test. Last is palatal asymmetry. What you're doing is you're having the patient open their mouth, and you're looking at their uvula, and you're having them say, ah. If they have no weakness, the uvula will just lift up and come back down. If they have weakness, the uvula, when they say ah, will swing to one side. If they have that, you would say yes, you would stop the test, you would not give the water test. If at any point the answer is yes to any of these questions, you stop the test and do not give them the water, and they fail until speech sees them. If all answers are no, then proceed on to the water test. Just a few items for this. In order for the patient to be able to pass this test, all items say no, and the water test says pass. If any item is not completed, then we have to consider it as the patient has failed or the patient has had an incomplete dysphagia screen, and it does not meet the criteria that we need to correctly assess that patient. Little clarification as well, or really a reminder, if the patient has an NG or OG or some type of feeding tube, please make sure that you're verifying that your orders, the medications that you're giving the patient, do not say oral. It can be very easy when we're, moving very quickly to scan the medications and crush them and administer them and not realize that that order says oral. We know that we're not giving them the pill down their mouth while they have a feeding tube, but we have to show that we're not doing that by making sure that the orders themselves say feeding tube. VTE prophylaxis. So this has to be done within the first 24 hours from the patient arriving to the hospital, not to the unit. From the time the patient hits the ED, or if they're direct transfer straight to the unit, you have 24 hours to have this intervention done. That means that we have to make sure that we've documented that the SCDs are on the patient, or if the patient does not want to have them, if the patient's refusing, we need to document that they refused it. Also, what else would meet this criteria? Lovenox being administered within the first 24 hours, heparin being administered. If they're on an anticoagulant like Coumadin and their INR is therapeutic, then that's fine. That meets the criteria. But overall, the easiest way is to make sure those SCDs are on the patient. The SCDs are actually, the order for them is embedded in the stroke pathway. So when the physician orders the stroke pathway, the order is already sent down to central supply. Make sure that if you're coming near 24 hours, especially if that patient's still in the ED, that we're contacting central supply and making sure that those SCDs are coming up and we can place them on the patient. Antithrombotic therapy by the end of day 2. This is making sure the patient that has an ischemic or a TIA has aspirin, Plavix, or Brilinta like in their mouth before the end of day 2. So it needs to be documented as administered, or we need a physician's note as to why we're withholding, or if the patient's refusing, we need to make sure we're documenting the patient's refusing that medication. Okay, so what this is a core measure worksheet for our stroke patients. It's a comprehensive core measure worksheet, and it's available in your stroke book. So the core measures are uploaded in the stroke pathway as the items on the front of the patient's chart that need to be completed in that 24-hour time period. However, if you'd prefer a paper version to keep yourselves on track, you're more than welcome to access it in the Code Stroke book. Make sure when we're receiving a patient from an outside facility that we are documenting not only the report from the outside facility, but also the report we've received from EMS. The reason why that needs to be done is because if we have patients that are being sent to us, they're being sent to us because they're having a stroke, right? If they're being sent to us and then all of a sudden that patient during transport declines and has to go to IR instead of the unit, then those that are in IR will have the same report that whatever nurse took the report has. So this is .code stroke report. You would go into your progress notes and you type .code stroke report and you fill this out prior to the patient arriving to the hospital. You can see at the bottom it says utilize .code stroke EMS report to document the EMS to RN report upon patient arrival. We need to make sure that we are documenting that we received report from EMS, what happened during the transfer. That's what we're looking at, right? So make sure when the patient arrives that we're going into a progress note and we're typing .code stroke EMS report. This is what populates when you type that in. First of all, please make sure that you're documenting in there the time of arrival to the hospital. When we create patients' charts, we have to do that ahead of time, so that way when they hit the hospital, we're able to care for the patient right away. So sometimes when we create that chart a little bit earlier, it kind of displaces the time of arrival. So we need to make sure that we are documenting time of arrival to hospital right here. Next, if you go on to the next line, vital sign trends during transfer, and click F2, I'm not looking for the actual vital signs. I don't need you to document systolic, diastolic. This is going to say increasing, decreasing, or remaining stable. That's all I need to know. For neurochecks, same thing, improving, deteriorating, or remaining stable. Medications given during transfer, this is only if EMS gave medications between the outside hospital and our hospital, or if any medication was hanging during transfer. You're going to fill that out. Otherwise, NA. Did the patient receive alteplase at the outside hospital? If so, then what was the status during transfer? Was it still dripping when the patient came in and still infusing? Was it completed? Was the saline flush administered by EMS? If not, NA, NA. Tenecteplase, did the patient receive that? If yeah, then go ahead and fill this out. And what time was the medication initiated at the outside hospital? All right, now that we've gone through that, let's go ahead and go through some stroke education. So why do we care about strokes? Well, there's about 800,000 strokes that happen each year, and it's the fifth leading cause of death. It used to be the fourth, but because we've gotten so much better at treating these patients with thrombolytic therapy and mechanical thrombectomy, it's moved to the fifth leading cause of death. You can see it's the number one cause of disability among adults in the U.S., and about every 40 seconds, someone has a stroke. All right, this is just a really great picture. Just a lot of vasculature in the brain, right? So your brain is only 2% of your total body weight, but it requires up to 20% of your body's blood supply at all times. The brain needs to be bathed in blood in order for it to function appropriately. And anytime there's a stenosis or there's a blockage, that flow to that brain slows down and that brain tissue becomes affected. And when it becomes affected, it stops functioning as well. And that loss of function is the weakness that you're seeing in that patient, or those signs and symptoms, those focal neurodeficits that you're seeing in the patient is a direct relation to the slowing or stopping of blood flow to that brain tissue. If you put the ends of the capillaries together, what you end up with is about 400 miles of capillaries. Lots of places for clots to get stuck. Okay, cerebral circulation. So when we look at this, these are the vessels that we have a lot of large vessel occlusions in. I'm not expecting you to memorize the vessels, but it is beneficial if you're able to understand what those vessels feed, and therefore what would that patient look like if they are having a stroke in that area. So to me, first of all, this looks like a little guy, all right? We have the legs here. These are your vertebral arteries. They feed the back of your brain. You have your basilar artery here, the little abdomen. You have your circle of Willis here, the little head. And then you have your middle cerebral arteries. This is your left middle cerebral artery. This is your right middle cerebral artery. And I always say those are kind of like big bushy eyebrows. And then you have this little colic that comes up off the top of the head right there. So what does it look like if you have a clot in a vertebral artery? Well, the vertebral artery feeds the back of the brain, right? It's posterior circulation. So if you have a clot stuck in a vertebral artery, that patient will end up having like a dizziness, right? A balance issue or some ataxia, which is lack of coordination. They oftentimes have vomiting, nausea and vomiting that go along with that dizziness feeling. And it can be with or without vision change. So what does that dizziness look like? If you have a patient that's all of a sudden dizziness, nausea, vomiting, it's easy to kind of go down the wrong track, not realize that it's a posterior stroke. So as a nurse, you really need to drill into what is that dizziness? What does that look like? And that dizziness is an acute onset of persistent dizziness. It does not change if they sit up, lay down, stand up. So it's not orthostatic. It does not change if they take their head and move it to the side really quick, where, vertiginous or vertigo. With vertiginous symptoms, you would get really bad dizziness when you have a quick head movement, and then it would stabilize. That is not posterior stroke. Posterior stroke is I was sitting here watching TV and all of a sudden I'm dizzy and it's not going away. So I really need you to drill into that dizziness and clarify it, what that means and what that looks like to that patient. Next, you have your basilar artery. This is the main artery in the brain. It connects anterior circulation to posterior circulation. It's a main artery in the brain, okay? High mortality rate if we have a clot stuck there. It's about an 85% mortality rate for basilar artery occlusions. Excuse me. So what does that patient look like if they present with a basilar artery occlusion? That patient usually presents one of two ways. Either they're completely obtunded, unresponsive, or two, they present as though they're very drunk. So the basilar artery occlusion, it's actually associated with a syndrome. It's called locked-in syndrome. Locked-in syndrome is where you are completely paralyzed. Your entire body's completely paralyzed except for your eyes. And you are cognitively aware of everything that's happening to you. You're literally locked into your body from that point on for the rest of your life. If they don't have this locked-in syndrome, then what they can present, right, they'll present like the dizziness, the nausea, the vomiting. They can have slurred speech. They can have vision changes. They can even have a rhythmic hiccuping or a belching that goes along with that basilar artery occlusion. They'll be very ataxic, so it'll look just like they're drunk. Make sure that we kind of have that in our heads if we're caring for someone. An example would be if we're caring for a patient that has a history of alcoholism and the patient's brought in and the family's saying, this is not what he's normally like when he's drunk. This is different from his normal state when he is drunk. That should probably perk your ears up a little bit, right? Little red flags going off. Maybe this isn't him being drunk. Maybe this is something a little bit more than that. Next, you have your circle of Willis. It's about the size of a nickel, and it's really there to help reroute blood if there's a blockage in one artery. It's not uncommon to have an incomplete circle of Willis. We've had a decent amount of patients here that are just born that way, and that's fine. It's just a birth defect, but it's really there to help reroute the blood. So if you were to have a blockage in the left MCA right here, then the blood can actually go around the circle of Willis, up the ACA, around using collateral circulation, and feed that area for a little while. Okay, so your internal carotid arteries, you have your common carotids that come off the aortic arch. Your common carotids split into the internal and external carotid arteries. And for neurology purposes, we're only going to focus in on the internal carotid arteries, or ICA. Your ICAs come up, they touch the circle of Willis, represented right here, and then they would continue on into your MCAs. So let's talk about what a patient with an MCA occlusion looks like. Part of it's based on where the blockage is located in the MCA. But overall, let's look at what the left side of the brain actually controls. So the left side of the brain actually controls your language. That's first and foremost, left language. And I'm not talking about slurred speech or garbled speech because that's going to come along with any type of facial weakness. What I'm talking about here is the Broca's area, right? Or Wernicke's area. I'm talking about aphasia, whether it's expressive or receptive. So with expressive aphasia, you have to understand that if we're trying to assess it by using an emotional statement, such as repeat after me, no ifs and, or I'm sorry, repeat after me, I love you, today's a beautiful day, they're going to be able to repeat that statement because it's emotional and it's emotions housed in multiple different areas of the brain. So you're not actually isolating that area that we need to test. So a rapid way would be to tell the patient, repeat after me, no ifs, ands, or buts about it. That is the single hardest statement for them to say. There's no emotion attached to it. So you can have patients where you can test that have aphasia, where they can say, I love you, no bits, dens, bends, today is a beautiful day. So we're looking for aphasia. And also when we're trying to assess patients for receptive aphasia, that is being able to understand what you're telling them, we can have them follow direction. Okay, for an example, we can have them hold up your thumb on your right hand, show me a pinky on your left hand. That's perfect. The only thing I say to that is please don't mimic what you're wanting that patient to do. Because if they have receptive aphasia, they're going to understand simply by the tone of your voice that you're requesting them to do something, so they will copy your movement. Okay, left language, that also means right-sided weakness. So the left middle cerebral artery feeds the area in the brain more of the arm than the leg. So although you'll have right-sided weakness, the arm will be more weak than the leg will be. There's also one other thing that comes along with middle cerebral artery strokes, and that's a gaze preference. Your frontal eye fields press against each other, similar to if you hold your hands up and press your fists together. They press against each other at all times to maintain focus. If I were to have a right-sided stroke, my right frontal eye field would go weak, but my left would continue to do its job. And so it offsets where your eyes relax to. So if I'm having a right stroke, my eyes will be pointing to the right, and my left side of my body would be weak. Your eyes point to the location in the brain where the clot is. Okay, let's move on to the right MCA. So your right MCA, which is right here, feeds the right hemisphere of the brain, and you would have left-sided weakness, again, greater in the arm than in the leg. You would have right-sided gaze preference, and you would also have neglect. So that's specific to the right side, right? Neglect, RN, right? Neglect. How can you assess that rapidly? So what we do is we actually do an assessment called double simultaneous stimulation, which is actually very simple to do. You have the patient close their eyes. You would touch one knee. They could say the right. You touch the other knee. They'll say the left. But when you touch them at the exact same time, they will only pick up one side sensation. So they might say right, left, and then when you touch them both times, they'll say right. Do it on the legs, do it on the shoulders, do it on the face. Please avoid the hands and feet for purposes of neuropathy. All right, next you have your ACAs coming up here. This is the little colic of the gentleman or the female. And so what this ends up doing is this feeds I know we talk about ACAs, we talk about personality changes, but in the acute time that you have that patient, it's easier to identify that there's going to be a bigger weakness in the leg than there is in the arm. So the ACA feeds the location of the leg on the motor strip than it does more the arm, okay? So again, you have two internal carotid arteries on the sides of your neck. It turns into the middle cerebral artery, and then you have your vertebral arteries in the back of your neck, and they all meet together in that circle of Willis right there, okay? All right, so this is a picture of the brain. If I were to look at you, directly at you, and you were to just kind of slice my brain, right? This is your internal carotid artery coming up. This would be your circle of Willis here. And you have the internal carotid artery coming up, touching the circle of Willis, and continuing on into the middle cerebral artery. So a few things here, okay? Understanding if we have a clot stuck in the internal carotid artery, let's say right here, it cuts off all this blood supply to that hemisphere of the brain. So if you hear an ICA occlusion or an M1 occlusion, there is a significant portion of the brain that is being killed or injured at that time. So you have your M1 located here. Your M2 is at the bifurcation here. You have M3 and M4. And M4 goes out, it's smaller portions of the MCA. It's not considered small vessel. It's just the ends of the MCA. If you're looking at small vessels, that would be your little lenticular striae, these little capillaries here that feed the subcortex of the brain. So your middle cerebral artery feeds the cortex, or the outside of the brain. And you have capillaries that feed the subcortex, or the inside of the brain. Why do we care about labeling the MCA? Well, it's really simple, actually. So our equipment to go in and perform a thrombectomy really can only get to proximal M3. Once you hit distal M3 or jumping into M4, that vessel's too small for any neuroendovascular equipment to get into. So if you have an M3 or an M4 occlusion, those patients would benefit from thrombolytic therapy. If you have a patient with an occlusion in proximal M3, M2, M1, or ICA, we can go ahead and take them to CVI and remove that clot. Circulation distribution, this is just a nice picture. I'm a visual person, so I assume everyone else is too. Okay, so vertebral arteries, your posterior circulation, the little legs of that man. The posterior circulation would feed your blue area here. This is your posterior cerebral artery, feeds blue, okay? Your ICA would feed the red and the yellow together. So if you have an ICA occlusion, you can see what a large area of the brain is actually being cut off. If you have a middle cerebral artery occlusion down in the beginning, let's say M1, then you can see it's the red area by itself. So it's still a significant portion of that hemisphere that's being injured, right? And that's why we have to move so fast during code strokes to get the patient the treatment, because it's such large areas of these brains that this patient's going to be either permanently disabled or pass away. So what is a stroke? Well, essentially, stroke is just a disruption of blood flow to the brain. It can either be from a blockage, it can be from a hemorrhage, it's just disruption of blood flow to the brain. We're going to talk about three main types of stroke. So the first we'll talk about is hemorrhagic. Hemorrhagic in and of itself is about 13% of all strokes that come in. When you break hemorrhagic down, it ends up being 10% roughly is intracerebral hemorrhage and about 3% subarachnoid. And then you have ischemic stroke being 87% of all strokes that come in. We will talk about TIAs and stroke mimics as well. So let's start with hemorrhagic stroke. Subarachnoid hemorrhages can either be aneurysmal or it can just be a vessel rupture. It's just that where did that blood go when the aneurysm or vessel ruptured? If it goes into the cerebral spinal fluid in that subarachnoid space, it's a subarachnoid hemorrhage, right? When that blood's in that cerebral spinal fluid, it's actually really irritating to the brain, and it irritates the meninges as well. So some of the symptoms of subarachnoid hemorrhage actually mimic meningitis. They can have that neck pain, that neck rigidity. They can have light sensitivity, nausea, vomiting. We'll go through that a little bit later as well. So essentially, what you have is you have blood that's going into the cerebral spinal fluid and coating the brain in blood, all right? It's mixing very well with that cerebral spinal fluid. It's a really deadly disease process, subarachnoid hemorrhages. If you quantify the data, what you end up with is 25% of subarachnoid hemorrhage patients coming back to normal or near normal, 25% that are significantly disabled, and 50% that end up at some point passing away from the subarachnoid hemorrhage. You don't have to have an aneurysmal rupture that just occurs and done. You can actually have what we call a sentinel event, which is where that aneurysm starts leaking some of the blood into the cerebral spinal fluid. It hasn't fully ruptured, it's just kind of leaking. It's going to rupture if we're not able to treat it and stabilize it. It definitely has the potential to rupture. But you can have this sentinel event up to 1 week before that aneurysm ruptures. It's not going to be the worst headache they've ever had in their life. It'll just feel different from their normal headaches or different from their normal migraines. If you have an aneurysmal rupture, often what happens is at the point of the aneurysm rupturing, the patient syncopizes. So the patient passes out, wakes up, and now they have the worst headache they've ever had in their entire life. And again, if they're migraine sufferers, they might not say this is the worst headache I've ever had. They might just say this feels different from my normal migraine. This is just a visual picture. So if you have a subarachnoid hemorrhage, this is essentially what it would look like. So again, the blood is just kind of bathing the brain because it's mixing with the cerebral spinal fluid. So what does it look like when we have a patient come in and go to CT? So an easy way to kind of read imaging, first of all, is visualize the image as if you're standing at the foot of the patient. If you're standing at the foot of the patient, this is the left side, this is the right side, and the nose is up, and the feet are towards you. Okay? So that's first and foremost. Secondly, know that on imaging, blood is brighter, dead tissue is darker. All right? If this image is super bright, that shows you bone right out here. You can see the super bright skull. If it's super dark, that's going to be a nice clear ventricle. But you can see here, we have this highlighted starfish shape. This is the blood running alongside those large vessels that we were talking about before. Vertebral arteries, you have a basilar artery right here. It'll look like a little dot, kind of like you're looking down a paper towel tube, right? So you're looking down into the basilar artery. You have the circle of Willis right here, and you have the MCAs right here and here, and then you have the ACA going up top. If there's enough blood, it'll highlight like a starfish. If there's not enough blood, it might look just like a normal CT. So how can we assess whether the patient's having a subarachnoid hemorrhage if there's not enough blood to show on imaging? Well, remember, that blood is mixing with that cerebral spinal fluid. So let's test the cerebral spinal fluid. We can do a lumbar puncture on that patient, right? What are some requirements for subarachnoid hemorrhage patients? So first of all, they're in the hospital for a very long period of time because we are monitoring them for vasospasm. Again, the length of stay would depend on how bad that subarachnoid hemorrhage patient is. So let's look at the requirements that are needed for these patients. So nimodipine or Nimotap needs to be administered in the first 24 hours for a subarachnoid hemorrhage patient, or if they're going to have a procedure like an EVD or a coiling, it needs to be administered before the intervention. Or we need to have a documented reason why we're not giving that medication. So some of the medical books will say that nimodipine actually helps with vasospasm. However, nimodipine actually happens to help the oxidative damage that's occurring when the blood's breaking down in that cerebrospinal fluid. Either way, we need to make sure that that nimodipine is administered in the first 24 hours. Next, we need to make sure we have our neurocheck documentation on point. Please make sure that you have your 2 1-hour neurochecks in there. And again, your neurocheck is your modified NIHSS. We need to have our blood pressure under control. Essentially, what you have is a garden hose that has sprung a leak, and there's a little patch covering it. So prior to the patient having that aneurysm treated, we would have to have blood pressure control under 140/90. If they're on any anticoags, we're going to want to reverse that. We're going to want to have intracranial pressure monitoring if needed. Sometimes the patients have an EVD or a brain drain placed before they have to go get coiled. We need to monitor for vasospasm. Vasospasms are constriction of the blood vessel, and it can either be out, affecting areas in the cortex, which if the patient's wide awake and able to move, might show up like stroke symptoms, or it can happen in the subcortical area, which um, might not show. And think about, a lot of these patients are actually intubated or sedated. So how can we assess if the patient's having vasoconstriction? We have to do serial transcranial Dopplers, right? So every day the patient would have a serial transcranial Doppler to look for vasospasm. And then we need to make sure that the providers are documenting the severity score. So how do we treat aneurysms? Well, it depends. Number one, it depends on, are they ruptured or unruptured? What's the location? Are we able to easily get to that aneurysm? What's the shape of the aneurysm? How at risk is it for rupturing? So first of all, there are patients that walk around, or people that walk around and they have aneurysms. It's like 10% of the population walk around with an aneurysm, and it doesn't affect them, and it doesn't grow, and it never ruptures. So if the aneurysm's stable and it's small and it's not at risk for rupturing, neuro might just monitor that aneurysm to see if it ever does grow or change shape. If the aneurysm is ruptured, then we will want to coil that aneurysm. So if the aneurysm ruptures, just like if you have a nosebleed, right? If you have a nosebleed, you're eventually going to make a blood clot there, right? In an aneurysm, once it ruptures, your body has a tendency to make a blood clot there and kind of embolize the aneurysm itself, or stabilize that aneurysm. Okay. It's very rare that the patient will rupture multiple times. Usually, once your body makes that blood clot, it kind of stabilizes itself. Then we need to make sure we're coiling it within 24 hours of the patient arriving. However, if the patient's arriving and actively bleeding, we need to coil it immediately. So how do we coil? Well, this is the first picture here. This is coiling. We would puncture in through the femoral artery. We feed a wire up to the brain. The coils are made out of platinum. You can have different lengths or different amounts of them. And the first coil that goes in makes kind of a cast of the inside of the aneurysm. And then you would go ahead and put other coils in there as well. You don't need to have 100% packing density, meaning you don't have to stuff it full of coils, right? You just need to have enough coils in there so that way the coils disrupt the blood flow, the blood coagulates with the coils, and it embolizes the aneurysm. It stabilizes it it stabilizes it, and then its path of least resistance for the blood flow, it just continues on in the vessel, no longer going into the aneurysm. Clipping is another option that they have for aneurysms. You'd actually remove a piece of the skull and you would place a clip on the neck of the aneurysm. And just like coils, the clips would stay in the patient's brain. And then it's, again, path of least resistance for the blood. It no longer goes into the aneurysm, it goes past it. So this is what coiling would look like if you were down in IR, or CBI, sorry. You have a nice shaped vessel here, and then you have this little aneurysm coming off, or I should say a large aneurysm coming off of this vessel here. You can see the reason why it's darker is because that's where the blood flow is going, that's where the dye is going. After you coil it, you can still see the shape of the aneurysm here, but you can see there's no more blood flow going into that aneurysm. So the aneurysm is stable. At that point, you might be asked by the neurologist to go ahead and just kind of let the blood pressure normalize after that aneurysm is stable. So subarachnoid hemorrhage, so clipping of an aneurysm, it's the most invasive and kind of least preferred, just because we're able to take care of the aneurysms from an endovascular point of view at this point, but it is still used in certain situations. Okay, these are aneurysm treatments, and this would be for patients that aren't bleeding. They have just an unstable aneurysm. So the first thing we have is this liquid embolization. We use like an onyx glue. Just inject the liquid embolization into the aneurysm, and then it would harden. And again, we're just filling that aneurysm up so it no longer grows and it's stabilized, and a path of least resistance, the blood would flow past the aneurysm. On the right side, you see a flow diverter being used. We use we call it Fred. Essentially, you're literally laying like kind of like a garden hose, right? It's a covered stent, so you're laying it in the vessel, and it's just bypassing the blood. The blood's just continuing through that tube and continuing on into circulation, bypassing the aneurysm. So you heard me talk a little bit before about severity scoring and what that means. We're really just grading how bad the subarachnoid hemorrhage is, how bad or good the subarachnoid hemorrhage is. And so what you might see documented in the chart, and again, this is not for the nurses, this is for the providers, would be a Hunt and Hess. So you might see H and H. And the next one we'll talk about is the Fisher, but the Hunt and Hess looks at the classification for the subarachnoid hemorrhage. So you can see here, grade 1 would be asymptomatic or a mild headache. Grade 2 would have moderate to severe headache, nuchal rigidity. 3 is mild focal deficit with lethargy and confusion. 4 is stupor, and 5 is deep coma. The next portion of the severity scoring is the Fisher, and the Fisher is really looking at location of the bleed, right? Or how much blood there was involved in it. So was it focal and thin? Was it diffuse and thin? Was it thick? Or was it focal or diffuse thin subarachnoid with significant ICH or IVH, which is interventricular hemorrhage? So this grade is associated with the percentage of the patient becoming having symptomatic vasospasm. So what is a vasospasm and what does that look like? Well, when that vessel is irritated, that vessel clamps down. It vasoconstricts. It cuts itself off of oxygen and blood, right? So if you look at this image on the right, this would be a normal, right? This is a normal vessel. This is actually, I know it says after vasospasm treatment, but really this is essentially what it's supposed to look like in the beginning. So technically, this would be before vasospasm. The image on the left would be during vasospasm. So you can see during vasospasm, this vessel gets really tight right here, right kind of where the arrows are pointing. Not just that though. Look at how dark from before to during. Look at the change in color in the vessels. The vessels on the right before the vasospasm are darker than the vessels on the left that are occurring during vasospasm. But not just that, look at all the supportive collateral. So you can see over here on the right, you have these nice vessels, and over here on the left, they're starting to disappear in 3 separate locations, 1, 2, and 3. During that time of vasospasm, that brain tissue is being starved of blood and oxygen, and guess what's happening? Those areas are starting to stroke out, right? Now we're having like an ischemic stroke at that area because that vasospasm is impacting that transport of blood and oxygen to that brain tissue. We have to get these patients down to CVI because we have to treat that vessel spasm. Once we're able to treat that vessel spasm, so we'll deliver medication interarterially. Once we deliver that medication, the vessel will release and go back to normal. So this would be, again, after. Most common causes of subarachnoid hemorrhage overall would just be essentially trauma, right? And then Berry aneurysms. So for Berry aneurysms, those are the aneurysms with a small neck and a big head. It's 90% The Berry aneurysm is 90% of all cerebral aneurysms. And the risk factors for Berry aneurysms include untreated hypertension, cigarette smoking, drug abuse, and unfortunately for me and lots of nurses, heavy caffeine intake. Luckily, we know Bansol, so we're good to go. All right, so next we're moving on to intracerebral hemorrhage. So intracerebral hemorrhage is 10% of all stroke patients that come in. So again, it's either an artery or an aneurysm that ruptures. It's just that where did the blood go when it ruptured? This time, instead of going into the subarachnoid space, it went into the brain tissue, okay? That blood that's gushing into that brain tissue is essentially squishing that brain tissue. It's putting pressure on that brain tissue. And that pressure leads to death of that brain tissue, loss of function, and also it's compressing the capillaries that are around that area as well. We do have to watch out with any change in fluid or matter in the brain. Obviously, one of the things you have to watch out for is herniation or, symptoms leading up to herniation. So what does it look like on a CT scan? So on a CT scan, again, blood is bright, dead tissue is dark. It's going to be located within the brain tissue. So you can see here, this is a nice ICH. What do we do for intracerebral hemorrhage patients? Life-saving measures, right? If they're on any anticoags, we're going to want to reverse that. We're going to want to control their blood pressure. Again, just like subarachnoid hemorrhage, less than 140/90. Intracranial pressure control. We'll do supportive services. And there is opportunity there if patients fit certain criteria to do craniotomy or an evacuation if they fit criteria. So we have a severity scoring for intracerebral hemorrhage, which is similar to subarachnoid hemorrhage. So this you'll just see ICH equals or ICH 4. We're documenting the severity score of that patient's intracerebral hemorrhage. And you can see here what it's basing itself on is Glasgow Coma score, age of the patient, location of the bleed, how much blood was involved, were the ventricles involved. That gives you 0 to 6 points. And that 0 to 6 points is associated with a 30-day mortality rate for these patients. Requirements for intracerebral hemorrhage, again, we need the blood pressure control under 140/90. We need neurochecks Q1 hour unless otherwise specified. You're going to want to monitor for Cushing's triad. It's easy to forget what that is, so we'll go over it in a little bit here. And these patients need to have a hemorrhagic pathway ordered. Again, also for the non-traumatic subarachnoid hemorrhage, they both need a hemorrhagic pathway ordered. That pathway includes almost all the items the provider needs to order and all the items the nurse needs to complete in order to stay in compliance for the stroke program. Also, when you have that stroke pathway uploaded or ordered, once the provider orders that, your care plans for that patient and the education needing to be provided to that patient are both automatically uploaded. So it's beneficial for us to make sure that that's ordered. Okay, let's go over Cushing's triad. So Cushing's triad is the signs and symptoms the patient's going to present to you if they have increasing intracranial pressure, right? And these symptoms will present prior to that patient having a blown pupil, right? So what does increasing intracranial pressure look like overall? You'll have increasing of systolic blood pressure and at the same time decreasing of pulse and respiration. So when you walk into a patient's room, make sure that we're not just looking at one set of vitals and saying, oh yeah, okay, that patient's stable. Make sure you're trending those vitals, right? An easy way to remember Cushing's triad is that it's opposite of shock. And please remember this Cushing's triad, it is not just for hemorrhagic patients. This is also for the ischemic stroke patient that had, tenectoplace, or the ischemic stroke patient that had a procedure, right? This could be any of our patients. So make sure that we're comfortable kind of bringing out the signs and symptoms of Cushing's triad from our memory while we're caring for these patients. Okay, so this is just looking at etiology for all head bleeds. This is kind of encompassing kind of all purposes of head bleeds, okay? And it spells out the word chatty. So C is cancer, and that would be a brain tumor that started bleeding. H is hypertension. Do you remember earlier when I spoke about those tiny little small vessels, those lenticular striae, the ones that feed the subcortex or the inside of the brain? Those are the ones that are at higher risk for bleeding due to hypertension. You have aneurysm or AVM that ruptures. You would be able to see that aneurysm or AVM on imaging. You have amyloid angiopathy, and this actually I think is really interesting. So I know we've heard of amyloid before, and maybe it's going to be kind of far back in your memory that you're going to pull it out from. But amyloid issues occur with patients that have Alzheimer's. So those kind of misfolded proteins get embedded, right, in the cortex of the brain. It's not just in the neurons that it gets embedded in the vessel walls. And so when they get embedded in the vessel walls of the cortex of the brain, it makes them at a higher risk for rupturing. So going back to this image here, intracerebral hemorrhage, if you have a patient that has a hypertensive hemorrhage, right, a hemorrhage from high blood pressure, if there's no brain tumor, no AVM, no anything else that's the cause of the bleed, and the bleed's located in this kind of area here, it's going to be a hypertensive bleed. If you have a patient with a head bleed out in the cortex of the brain, so out here, right, and don't forget the cortex kind of dips in here and comes back out, and they have no other reason for it, like no trauma, no brain tumor, nothing like that, then it most often is going to end up being some type of amyloid angiopathy. Going back here. All right, next is going to be trauma, obviously. Trauma can cause a head bleed. And then the final one is ischemic stroke with a hemorrhagic transformation. So it's not just, obviously, during a stroke, it's not the neurons themselves that are just getting killed, it's also the vessels, right? So the vessels are also being injured or damaged. So you can have a hemorrhagic transformation with that. So some signs and symptoms of a hemorrhagic patient would be a thunderclap headache. You see that more often with the subarachnoid hemorrhage patients. Again, worst headache of their life, 10 out of 10. I feel like my brain's going to explode. You can have a decrease in or loss of consciousness. I see nausea, vomiting a lot in these patients with head bleeds. You can have an acute onset of confusion or delirium, and it can be with any other stroke symptoms, arm weakness, facial weakness, slurred speech, anything like that. Okay, so we've talked about hemorrhagic stroke, subarachnoid and intracerebral hemorrhage. Let's move on. Let's talk about TIA and stroke. I know you know what a TIA is, but for fun, let's go over it anyway. So essentially, I'm going to give you a really cheesy kind of imagery here, and bear with me, okay? So you have your arteries in your brain, and your arteries are like a garden hose, and you have your brain tissue, and your brain tissue is like a field of flowers, okay? So when you have a garden hose that is permanently kinked, what ends up happening to those flowers? They die, right? That's a stroke. They die. You can look at the flower bed. You can see the dead flowers. You can see that they're never coming back. When you have a TIA, that garden hose, right, your artery, gets partially blocked. A little bit of blood flow gets through to that brain tissue, but not enough to support that function of that area of the brain. So that means that when that blood flow slows down, that area, even though it's not dead, will shut the function off in the brain. I always say it kind of wilts the brain tissue. As it's wilted, it's still alive. It's just trying to preserve itself. So that function in that patient might stop, like they'll have arm weakness now. But when your body is able to restore the flow, that brain tissue area, let's say by eating a little clot away, then that blood flow returns, just like the garden hose would flow back out to the flowers. And those flowers that are wilted are going to perk back up. That's the same essential thing that's happening in your brain. Your brain tissue is going to perk back up and the function will return. That person's arm weakness is now gone. I will never be able to look at those flowers and say those were wilted at one point. Just like you will never be able to look at imaging and say that patient had a TIA. It is not permanent damage, so you will not be able to see that. However, because TIA is essentially the same exact disease process as stroke, right? Because in TIA, the only difference was that your body ate that clot away before it caused permanent damage. And in a stroke, your body could not eat that clot away before it caused permanent damage. That's the only single difference, all right? So because TIA and stroke are so very similar and essentially the same disease process, you have to treat it the same way. So what does that mean? That means in the ED, if they're coming in as a code stroke, again, we're using that code stroke order set with the Q1 hour neurochecks until otherwise ordered or ordered differently by the ED doctor. That means that we need to make sure when they're in the hospital that they have the ischemic stroke pathway ordered, that they're getting all the same services, the NIHSS at the proper time, the dysphagia screen. Nothing changes just because it's a TIA and not a stroke. That doesn't change it, okay? Also, these patients need to be discharged on the same types of medications that stroke patients need to be discharged on. Medications would include like a thrombotic therapy by the end, by discharge, right? And so that's your anticoagulant or antiplatelet medication. And obviously we do that to help prevent the risk of making another blood clot in the future. We also have to make sure that they're discharged on a statin medication, a atorvastatin, simvastatin, as long as they can tolerate it and they're not allergic to it. We want to discharge them on a high dose of statin medication. I usually ask why at this point, but it's not a class, so let me just continue on. The reason why is because, first of all, it doesn't matter what their LDL is. It doesn't matter if it's less than 70 or, how much it is. They need to be started on statin medication that's a high intensity because it has like a neuroprotectant effect on the brain. It has an anti-inflammatory effect on the brain. So when patients have a stroke, yeah, the stroke damages, but also the inflammation that happens in that brain tissue causes further damage. So think about it. If I got punched in the eye on day one, would my eye be as swollen as it ever is going to get? No. Day two, it looks worse. Day three really is kind of that time where my eye would be at the most swollen point, okay? When you have an injury in your brain tissue reacts the same way any body tissue would react, and it will start to swell, right? That injured part can start to swell. If you have a patient that's on a statin medication that's a high intensity, they have a less likelihood that they are going to have as much swelling that's occurring from that brain damage from that stroke, okay? So they'll have a better possible better prognosis if they're on a high intensity statin medication. Okay, so let's move on to ischemic stroke. Ischemic stroke is 87% of all strokes that come into the hospital. And essentially, you just have blood flow that's cut off to the brain cells, right? And it can be thrombotic, which means that the clot's forming in the brain circulation, or it can be embolic, which means that something traveled up to the brain, whether it's clot, whether it's fat, whether it's, vegetation, traveled up to the brain and prevented blood flow from proceeding through that vessel, right? It blocked the blood flow, and now that brain tissue is starting to die off. So let's talk a little bit about embolic. Well, actually, let's back up. Let's talk about thrombotic. So you can have stenosis or blockage here. You can have blockage that's occurring in the larger vessels in your actual brain. Just like you can have stenosis in the arteries of your heart or, peripheral artery disease, you can have the same thing that's occurring in your brain, right? It's like one tube system, okay? So you can have stenosis in your brain. That stenosis can crack and make a blood clot in there, right? So that would be an example. It's called ICAD, which is essentially just stenosis within the brain, stenosis within the large vessels of the brain, intracranial. And so that would be an example of thrombotic stroke, okay? So embolic stroke, that would be where something's sent up to your brain, okay? So I know that everybody knows how atrial fibrillation works. I know you know that the top of the heart quivers and the bottom of the heart pumps irregularly, and it's trying to, just get blood flow out to the brain, right? Or out to the body, I should say. My question is, who's at highest risk of having a stroke from AFib? Is it those that are in persistent AFib, or is it those in paroxysmal AFib? So those in persistent AFib, they have a tendency for it to be caught by a provider somewhere and be treated with anticoagulants. So actually their risk of having a stroke is a lot lower than those that are in paroxysmal atrial fibrillation. So think about it. When you're in AFib, you lose that kind of extra cardiac output, right? When you're in paroxysmal AFib, you lose that extra cardiac output, that stretch that you need to give an effective ventricular contraction. During that time, blood flow is kind of slowed down in that atrium, those blood clots form, and then when the patient flips back into normal sinus, you have these great contractions, and now you're showering the brain in blood clots. All right? So that would be the example of how paroxysmal AFib patients are at a higher risk of having a stroke than those in persistent AFib. Also, think about it. People that have paroxysmal AFib, how many people actually feel when they're in atrial fibrillation? Now, let's say they feel it, because a lot of people don't, right? Let's say they do feel it and they go to the physician and they say to their primary care provider, hey, sometimes I'm feeling these, irregular heart rhythms, and they do an EKG. What's the likelihood the patient's going to be in paroxysmal AFib at that time? So then let's say they start them on a little, week-long monitor or 30-day monitor. There's even a likelihood that they might not catch that patient going into paroxysmal AFib during that time. So that's why the patient's at higher risk for that, okay? So now let's talk about PFO. PFO, patent foramen ovale, it's the little hole in your heart between your right atrium and your left atrium. And the reason why it's there is because you have it while you're in utero, because you don't have to use your lungs to breathe, right? So the blood is shunted from your right atrium to your left atrium, left ventricle, and then ejected out of the heart and, feeding the body. When you're born and you take that first breath, that has a tendency to close, and in most people, close and seal shut. But for some people, it doesn't, right? And so what ends up happening is having a PFO is kind of similar to having a screen door that's not fully latched in the summer. All right, a screen door on your house that's not fully latched during the summer. And when a big wind comes, that door has a tendency to swing open. And then when that wind goes away, the screen door shuts, right? That's essentially what's happening. when you change your pressure in your chest, okay, your inner thoracic pressure. You can change your inner thoracic pressure by doing things like having a coughing fit, bending over to tie your shoe, bending over to work on your car, anything like that, right? And during that time, that PFO can open, essentially. Now, here's the thing. Obviously, just having a PFO by itself is not going to cause a stroke, right? There has to be kind of this perfect scenario set up. So number one, if we have a patient that we think the clot came from or caused because of something else, but the patient has a PFO and we're linking it to the stroke, we're going to want to follow it back down the body, right? Because that blood clot came up from somewhere. So what we'll do is we'll do, bilateral ultrasounds, right? We're going to look for DVTs, okay? If we don't find anything, please keep in mind that it is actually fairly normal for us to make little tiny blood clots throughout the day. And those little tiny blood clots normally, come back to the heart and then they get pumped into the lungs, and your lungs actually have the ability to just kind of break them down, right? There's an enzyme that your lungs house that help to break down blood clots. And I'm not talking about big PEs. I'm talking about little tiny blood clots that come back to your lungs. It's one of the functions that your lungs has, is to act similar to like a net for blood clots and to break them down. If you have a PFO and that PFO happens to open, or you happen to change that pressure in your chest, at the same exact time a blood clot comes through, then that blood clot is going to essentially skip the net of your lungs, and it's going to go right atrium, right atrium, left ventricle, and to the brain. All right, so that's how PFO can be associated with stroke. However, that usually is caught in a much earlier age. The patient will have a stroke at an earlier age. The youngest I've seen with a PFO here has been about the age of 30. Usually after the age of 65, if they haven't had a stroke from that PFO, they're kind of in the clear. Okay, so ischemic stroke breakdown. What is the cause of ischemic strokes? That's where we're at right now. So right here, I just want you to look at the percentages. So 30% of the time for an ischemic stroke, you have something that's shot up from the heart. Who are these patients? Who are the patients that are at risk for having a stroke, right? As a forethought to our care for the patients, who are at highest risk for having a stroke? Obviously, this would be your AFib or your paroxysmal AFib, right? Obviously. But this would also be patients that have a low ejection fraction, right? So this could be your CHF patients with a low EF. This could be your patients that, have vegetation on their valves. This could be patients that have a left ventricular thrombus. That could be patients that have a cardiac myxoma, which is like a little tumor. For whatever reason, it's something that is shot up from your heart into your brain, 30% of the time from your heart. Small vessel, these are those little lenticulostriae. Remember those arteries I talked about earlier? They feed towards the center of the brain, or the inside of the brain, called the subcortex. These little vessels are at risk for shutting down due to risk factors that are not controlled. This would be your high blood pressure, your hyperlipidemia, your diabetes that's not well controlled, smoking, right? They all kind of essentially eat the ends of those capillaries away, or close the ends of the capillaries, and those little ends die off, and that's where you get your small vessel stroke. Sometimes you'll hear people refer to them as lacunar stroke. That's the older term for them. So again, these would be patients that you're really going to want to educate on risk factor modification. You have, one or two small vessels that close off. That's called small vessel stroke. You continue on without correcting those risk factors, then the patient can proceed on through to like a white matter disease, or small vessel disease is what I'm trying to say. And then still, if it continues on, they can actually proceed into what's called like a vascular dementia, where they've had so much of their brain destroyed by these small vessel strokes that they can actually go into a dementia for it. All right, next, 15% is large vessel strokes. So what are these large vessels? These are specifically extracranial, which means they are not inside your brain. These large vessels are your internal carotid arteries and your vertebral arteries. It would be stenosis of those arteries that would lead to a stroke, okay? You would see that on the results of the CT angio. It'll tell you if that area is stenotic. 10 to 20% is other, and then 20 to 40% is in this category, which is called ESIS, used to be called cryptogenic stroke. ESIS stands for embolic stroke of undetermined source. It still means the same thing. We still have no idea what has caused the stroke for this patient, okay? So it's essentially like an umbrella term. If we aren't able to say this is cardiogenic, small vessel, or large vessel, or some other purpose, then it goes under this term of ESIS. This is just another way to remember the etiology for all ischemic strokes. And it's essentially what I've already gone over. Small vessel, the best treatment in the acute setting would be tenecteplase, only if that patient fits the criteria, and then risk factor modification. For large artery, your extracranial, your internal carotid artery and vertebral, that would be like treatment of that artery with stenting of the artery, or a thrombectomy if needed, or tenecteplase if they fit the criteria for that as well. ICAD is your stenosis of your, MCAs or ACA, which are the vessels that are inside your brain, the intracranial vessel. That would be tenecteplase or a heparin drip. Sometimes we drive the blood pressure up and try to let the patient create their own collateral. Essentially, they have to fail medical management. If they decline at any point, then we would take them down to stent intracranially. But please remember that there's a really high risk for, oh gosh, I'm blanking out now. There's a really high risk for issues that come along with that procedure. The risk could be up to about 20% for complications. And then we have cardioembolic. You're going to treat the source of the embolus, right? You can do tenecteplase or thrombectomy for that. And then ESIS. Okay, so now we're back to ESIS, embolic stroke of undetermined source, or cryptogenic. You'll see it kind of presented in both ways. For that, if it's an ESIS stroke, then we're going to end up doing like an antithrombotic therapy. We'll do your statin, and we're going to look for we're going to end up having the patient on an extended cardiac monitoring. Sometimes they'll do a Holter device, and sometimes they'll do an implantable link device. It's just an implantable cardiac monitor. And the reason why is because research is showing more often than not that ESIS strokes just happen to be paroxysmal AFib that's never been caught. So this would be an example of an external, like a Holter monitor, right? This would be the example of the implantable cardiac monitor. So the larger one is how big it used to be, and now it's down to this little device here, which is called a link. If your patient gets it implanted, it just gets implanted kind of in the same location the pacemaker would go. They can do it on the floor, and it monitors the patients for a couple years. And it looks for about 2 minutes of AFib. Once it picks up 2 minutes of atrial fibrillation, then that would notify their call center, the patient's physician, and the patient. And then at that time, once AFib has been detected or proven, only at that time then can we start anticoagulant medication. Until we prove AFib for an ESIS stroke patient, we have to just do regular antiplatelet medication and a statin. We can't jump straight to anticoagulant. Okay. So we spoke before about the garden hose and the field of flowers. All right. So remember that. Bring that kind of cheesy imagery back into this. Okay. So acute ischemic stroke penumbra. We're going to talk about ischemic penumbra versus ischemic core and essentially what that is. So the definition of a penumbra, ischemic penumbra, is the at-risk territory for stroke. All right. And I don't know if you're anything like me, but I always hated that definition because I didn't feel like it gave a good visual to people about what that actually means. So essentially, penumbra is the area of the brain that's currently the wilted flowers. All right. It's essentially getting some blood, but not enough to show or retain the function. Okay. So what you have is you have on this image, you'll have your garden hose here. You have the clot right here, or essentially the kink in the garden hose. You have all that pink area, whether it's dark pink or light pink, it's your field of flowers. You have the dark pink area, the smaller location, that's the dead flowers. Obviously, they're never going to perk back up. They're never going to return. Same thing for brain tissue, right? And that happens during a large stroke, right? You're always going to have an area that's damaged permanently. But then look at this huge area of penumbra, right? All this light pink area is area of essentially wilted brain tissue. All we need to do is get the flow back to that brain tissue, and that entire area can perk back up, right? And it essentially will not have damage to it, right? But the outcome of that patient is directly related to how fast we are able to move, how fast we can get this patient into an intervention, how fast we're able to remove that clot and restore that blood flow to that brain tissue. Because think about it, you guys, it is not just, first of all, it's 1.9 million brain cells per minute that are being killed during a large stroke. Okay. If we're sitting here and taking our time, or we're afraid to call a code stroke because we're not sure if it is a stroke and we're kind of nervous about it, or if nobody's seen Aunt Tina since Tuesday, again, it's 1.9 million brain cells that are being killed per minute, and essentially the core gets larger and larger, essentially filling out that penumbra area. And the penumbra, as a result, gets smaller and smaller. Once the ischemic core hits about 50 to 60%, then it's no longer beneficial to go in there and try to remove that clot at that time. The reason why is because now it's not just, again, it's not the neurons themselves that's the only area of the brain being damaged. It's the actual vessel behind the blockage that's also being killed. So going back to the garden hose kind of imagery, if you have a garden hose, now think of it, this is like a garden hose now that's been sitting outside for years. Now it has holes in it, it's weathered, it's damaged, right? And if you turn the water on full blast, right, which is what your blood pressure is doing, it's going to try to push past it, and you unkink that hose, what you're going to essentially have is that garden hose is going to leak, or in the brain, you're going to have what's called a hemorrhagic transformation. You're going to have the damaged vessel rupture and bleed into the brain. So now they have a bleed on top of an ischemic stroke. It puts the patient at higher risk for complications and death. So it's incredibly important that we are able to intervene on these patients, get them moving through. If we're thinking it's a possible stroke that needs to go to CVI, that we're going to go ahead and prep this patient very rapidly, so that way we can get them out and get them to the intervention and save as much brain as possible. All right, so this is collateral circulation. Most people are born with good circulation. And so in this image, what you have is you have your MCA, middle cerebral artery, reaching up, right? And you have your ACA coming down and reaching down towards your MCA. If the fingertips of the capillaries touch, so if the capillaries meet, then essentially you have this ability to backflow the blood through collateral if you need it. Okay, it can feed this area down here. If you have poor collateral, if the fingertips of the arteries do not touch and you have a blockage, then essentially it doesn't really matter how fast we move, although no matter what happens, we always need to move fast. I want to clarify that. In a patient with poor collateral, it doesn't take the brain a long time to start dying off if it doesn't have glucose and oxygen, all right? If it's not being supplied with collateral circulation, then that area is going to end up dying. On the right, what you can see here is stroke with really good collaterals, all right? You can't build up collateral circulation in your brain in the same manner that you can, let's say, cardiac collaterals, right? So really, you're either A, born with really good collateral, or B, these are those 95-year-old patients with horrible cholesterol that their brain has been starving from oxygen and blood for so long that it's created its own little collateral system, okay? So you can see here on the right, this would be a patient that has a clot stuck in an artery, and the blood flow, it knows it cannot get past it, so the blood flow reroutes through the circle of Willis up, around, and back down to keep that area of penumbra just wilted but kept alive, okay? And those collateral vessels, they don't maintain forever, right? They only are able to support that brain tissue for approximately 24 hours, and then those will start failing, okay? So what is a CT, what is an ischemic stroke that already has damage look like on a CT? So if we have a patient coming in, and they're coming in as a code stroke, they'll come in and we'll get a couple pieces of information if we are looking at the possibility for tenecteplase, a thrombolytic therapy. A couple items we want to know would be what's the blood pressure, what's the blood sugar, are they on any anticoagulation, and what's the last known normal. The last piece of the puzzle would be a clean head CT. So let's say they fit all the other criteria for tenecteplase, and now we're bringing them to CT, and they're getting this image done. Let's say EMS, or if it was an inpatient code stroke, the previous nurse told you that the last known normal was 2 hours ago. And now you bring the patient down to the CT scanner and you see this on imaging. If they fit all other criteria, are we going to give tenecteplase? No. Why? Because, again, on imaging, on a CT scan, dead tissue is darker, blood is brighter. So you can see here, this whole area is essentially dead brain tissue. And how long does it take for dead brain tissue to start showing up on a CT? 6 to 12 hours. So in most cases, when code strokes come through and they get their initial imaging, the CT of the head will be negative. It'll look like nothing's happening in it. All right? And really, that's what we want if we're going to give tenecteplase. If we see something on imaging already, it's almost too late for us to go ahead and give tenecteplase or possibly even intervene, because we already know that the last known normal given to us is incorrect. because we already see the damage on the image. In certain circumstances, you can see something in the CT scan that essentially is the actual clot itself. So when we call a code stroke, the two images that are pretty standard are a CT, and so technically it's a CT stroke head, and a CTA head neck source. If we are inpatient calling a code stroke, please use the code stroke nursing protocol. It already has these items embedded in it. So sometimes, if this clot is very large and dense, it'll actually highlight the vessel itself. So in this patient had a large left MCA. So this is your MCA vessel here, your left side. This is your right MCA vessel here. And you can see comparatively, this one would be normal, and this one is much brighter, okay? And the reason why it's much brighter is because it's blood that's coagulated in that vessel, right? And so we call that a hyperdense MCA sign. It's not just that I wanted to point out, right? That right there tells us they're having a large vessel stroke, okay? The other thing I wanted to point out on this image, we can see that the patient's head is pointed straight up, right? But look at the eyes. See how the eyes are offset? This is an example of a gaze preference. When the patient relaxes their eyes, where is that relaxation point? If it's centered, they don't have a gaze preference. If they relax their eyes and their eyes offset to one side or the other, that is a gaze preference. So you can see right here in the CT scanner, the patient actually has a tendency to relax and kind of close their eyes, and their eyes will relax and their eyes will offset. And the side that the eyes look to is the side of the clot, right? This is another large vessel occlusion that we can see on regular CT scans sometimes. It's your basilar artery, all right? So again, it's kind of like looking down at a tube, and that's why it looks like a little circle. This is your hyperdense spot sign, basilar artery spot sign right here, okay? Again, the basilar artery is associated with locked-in syndrome, right? 85% mortality rate, so that spot sign should make us get up and go and get that patient to CVI. The second image we do during a code stroke is a CTA of the head and neck, not just a CTA of the head. We need to look basically from the clavicle up to see where there is a disruption of blood flow in the brain. Why do we do a CTA on a lot of code strokes? Because honestly, we've had a lot of patients that have come through with really, really good collateral circulation. And that really great collateral circulation will make the patient appear to be less symptomatic or having a smaller stroke. All right. And we don't know that they're having a large stroke until we do a CTA of the head and neck. And that test reveals to us that they're having a blockage at that time. Okay. So the CTA, it'll tell us if the patient has a thrombus in a large vessel, or it'll tell us if the patient's having stenosis in a vessel, okay? So when we look at this image here, you're going to look at the one on the left, and we are looking at the CTA of the head and neck, and this is just an example of a carotid artery right here that would have significant stenosis to it, and you would have what is tended to be called a string sign, string, S-T-R-I-N-G, string. You just have a little bit of blood flow getting through it. So again, it's just a carotid artery that has a stenosis in it. but it can be very symptomatic for that patient, and eventually that stenosis can rupture and it can create a blood clot at that site. It can also create another blood clot that it shoots deeper into the brain up to the MCA. The image on the right, you are again looking at the MCAs. And so here would be the MCA on your left. You can see it kind of, continues on, goes towards the back of the brain. And then on the patient's right, you would see that the vessel just stops. And right where that vessel stops, that right there is where the occlusion is. So the occlusion's right here. That thrombus got stuck right there. Oop, there we go. And so that would tell us that we need to activate, CBI, get that patient over there and get that thrombectomy going. The third image that we may add on would be a CT cerebral perfusion. And we add that CT perfusion on in cases where the last known normal is greater than 6 to 8 hours, or if it's just completely unknown. The CT perfusion is essentially a weather map of blood in the brain, right? One looks at flow of the blood, one looks at volume of the blood, the next one looks at time it takes for blood to get there. So I'm actually going to go over how to spot a stroke that has completed, where there's nothing else alive in that stroke area, versus a stroke that is being kept alive, or it has a penumbra, the wilted brain tissue, through collateral circulation. So looking at the image on the left, you see core infarct, ischemic penumbra, and you see CBF, which is cerebral blood flow, and you see CBV, which is cerebral blood volume. The top where it says core infarct, those images are going to be one patient, patient number 1. The ischemic penumbra, it'll be patient number 2, okay? So now, knowing that, and bringing back that cheesy garden hose imagery, whether you have an area of the brain that's dead or whether it's being kept alive, for CBF, cerebral blood flow, you're going to have low flow to that area. Because why? Because your garden hose is blocked. That makes sense, right? That's step number 1. Step number 2 is looking at the cerebral blood volume, CBV. So when you have an area of the brain that is dead, essentially your brain knows that it no longer has to feed that area of the brain. So it takes those blood vessels, and those blood vessels just do a prolonged vasoconstriction, and it moves all the blood out of that area that's dead, again, because it no longer has to support it. So you would have, or that patient number 1 would have a low flow of blood and a low volume of blood in that area. And that means that that ischemic stroke is completed, and we can no longer do anything to try to stop that stroke process. It has already completed. The patient number 2, ischemic penumbra, you'll see, again, you'll have the low flow. However, it knows it wants to keep itself alive. It's trying to do everything it can. So what you have is you have capillaries, those little collateral flow, and you have every capillary that's in that area dilating essentially to the point where it's almost fragile, right? It's trying so hard to keep itself alive, so it vasodilates. So when you vasodilate, you increase the volume of blood in that area. So for a patient that has one that we can still intervene on, what you'll see is you'll see low flow and high volume, all right? The third piece of the puzzle is looking at the time it takes for the blood to get to that area of the brain. Again, it would be much quicker for the blood to just travel up its normal flow, right? Straight up ICA, MCA, bam, right in the brain tissue, right? Versus, coming up the ICA and then going around the circle of Willis, up the ACA, coming back around, using collateral flow, trying to feed that area. that takes much longer time. So in here on the Tmax maps, purple and blue is normal. Red and green means that it's taking the blood longer to get there, okay? So on this Tmax, green is slowed blood and red is pretty much dead brain tissue, all right? So you can see on this image, this patient, yeah, they're having a stroke, and yeah, there's some area of the brain that's dead, but there's a huge area here, almost the entire left hemisphere, that's being kept alive through collateral circulation. Okay, I want to take a minute to talk about GFAST, not just because, it's a research project. Um, However, it was published in Frontiers Neurology August 2022, if you want to read the full article on it. But we're not going to talk about it because just because it's a research project. I want you as a nurse to be able to figure out how we can actually use the GFAST score to give us forethought on the plan of care for that patient. So what is GFAST? It's a large vessel occlusion screening tool. It is not saying, oh, is this patient having a stroke or are they not having a stroke? GFAST is, is it a small stroke that might benefit from, TPA or tenecteplase? Or is it a large stroke that's going to need endovascular therapy, like a thrombectomy or a stent? Okay. How can we assess that just by looking at the patient? So GFAST stands for gaze preference, facial droop, arm weakness, speech changes, and T is, time to perform the thrombectomy or time to give TPA. But essentially, it's gaze preference plus the FAST items. Gaze preference has a high specificity for large vessel occlusions. So if the patient has a gaze preference, they get 2 points for that. If they have any other item, facial droop or arm weakness or speech changes, that puts them at a level 3. Or a score of 3. So a score of 3 or higher means that that patient has a high likelihood that they're going to have to go to CVI to have an intervention. So if we're receiving the patient in from an outside hospital or receiving the patient in from EMS, and we do a quick calculation of the GFAST score, and that score is like, 4 or 5, and, we're sitting around waiting, we could be prepping that patient actually for that procedure, right? It's shaving off any minute that we can in any way possible to get that patient over to CVI to remove that clot or remove that blockage. So how do we assess for GFAST? Essentially, if you're going in there guns blazing looking for a gaze preference, I'm pretty sure you're going to miss it. All right. And think about it. Gaze preference, you have like a 50-50 shot of standing on the side that they're like preferring to look to anyway. And you're just going to think that the patient's really focused on you, right? You need to go into that code stroke, standing at the foot of the patient, and have everyone back off for a second and stop talking to the patient and stop touching the patient. And the patient will relax. And when they relax, their eyes will offset a little bit, all right? Their gaze preference is going to be opposite of the side that they're weak on. So if you walk in there and the patient has left-sided weakness, go to the foot of the bed and know the patient's probably going to be looking to the right. That's the way to figure out GFAST. That's a way to identify it and then use it as your plan of care, right? So now if the patient comes in and they're coming in and they have, facial droop and slurred speech, how many points is that? Right? We're at 2 points. That patient is probably only going to get like tenecteplase if they fit the criteria for it, okay? And they're probably not going to have endovascular therapy, all right? So GFAST of 0, 1, or 2, higher likelihood they're just going to get tenecteplase if they fit the criteria. GFAST of 3, 4, or 5, tenecteplase if they fit the criteria, plus possible endovascular therapy. So it gives you a forethought of what we're going to have to do for these patients in order to give them the best possible outcome. Again, time is brain. So it is 1.9 million brain cells per minute that are being killed during a stroke. In a large stroke, you have age acceleration, right? It's like an age acceleration that the patient experiences due to the damage that's occurring in the brain. So essentially, for each hour that the patient's experiencing that stroke, it's essentially the same as their age accelerating by 3.6 years. And in a very large stroke, it can even be up to, a total of 36 years per stroke that brain has a tendency to accelerate in the age, if that makes sense. The outcome of the patient is directly correlated to successful reperfusion. What are our options for patients that are coming in with a code stroke? All right. So again, number one, tenecteplase, right? So I have TPA on here because we do still get patients from outside hospitals that receive TPA or alteplase, but then we at our hospital provide tenecteplase. So I'm going to go through that. I'll kind of give an overview of both of them, but essentially they're really just chemical thrombolysis. Essentially, people call them clot busters a lot. They work better with smaller clots. They're able to eat them away a little bit easier. You still give them, even if the clot's larger, if they fit the criteria. It's just, it may not eat the entire clot away. All right. So for TPA, the dosage that the patient receives is 0.9 milligrams per kilogram. That gives you a total dose. 10% of that total dose is given over like 1 minute, and the rest is given in an IV over 60 minutes. Tenecteplase is 0.25 milligrams per kilogram with a max dose of 25 milligrams, which equals 5 milliliters. And how do you give that? You give that over like a 5-second IV push. But you don't just do that, right? You're going to do a saline flush. You're going to scan and document your saline flush. Then you're going to scan your tenecteplase. Then you're going to scan and document your saline flush afterwards, right? You need to make sure that you're showing that you did flush that tenecteplase in because it is such a small dose. We want to make sure we're not leaving any in the IV tubing. The window for treatment is the same for both medications. It's up to 4.5 hours from the last known normal. And just to be clear, make sure that last known normal is verified and accurate. So if somebody says to you, last known normal was when they woke up at 7 a.m., they had the facial droop, that's completely inaccurate. If this patient takes a nap and wakes up with a sign or symptom of a stroke, their last known normal is not when they woke up with the symptom. Their last known normal is when they went to bed the night before. All right? Just be very clear, and I'm going to use this for 1 second to talk about bedside report. We need to be doing bedside report for our neuro patients, really all patients, right? But for our neuro patients, we need to make sure that the neuro assessment of the nurse ahead of you is the same neuro assessment that you're seeing in the patient. We have code strokes happen, or we have stroke signs missed the most frequently during shift change. It can be easy to assume that the nurse previous to you noticed that weakness but maybe forgot to chart it. That's where we can get in trouble, right? We need to make sure that what that nurse has seen and that patient's experiencing is what now you see and you assess. So that way during your shift, you know that that patient's had those symptoms throughout the day, during the day shift, and into the night shift. And the reason, again, why I'm talking about bedside report too is just because that gives you a clear identification of that last known normal. So being at bedside, you can say last known normal is at 7 o'clock when you saw the patient, as opposed to, seeing them when they woke up from a nap in the morning, and now it's 9 o'clock, and the last known normal we have is, 4 a.m., right? So how do we know if thrombolytic therapy is appropriate for these patients? So the patient has to fit certain criteria that's set by the providers for inclusion, exclusion. So most of it is based off of the American Heart Association guidelines, but there might be little tweaks based on whatever hospital you're at that either add or kind of modify some of those criteria. But essentially, for us, when we have stroke patients, if we're calling a code stroke or if we're responding to a code stroke, there are certain things that we need to have together or pulled together in order for us to be able to treat this patient quickly. So number one is blood pressure. We need to know what the blood pressure is. Either if the primary nurse is calling a code stroke, then that nurse needs to either obtain or delegate someone to get a blood pressure and a blood sugar. That nurse should figure out the last known normal along with the stroke team. And also, we should know if that patient's on any anticoagulant. Do we care about aspirin and Plavix? No, not in this sense, right? We care about actual anticoagulants like Coumadin, right? So just a quick caveat to this, if a patient's on Coumadin, it does not automatically knock them out for tenecteplase. We can actually still get an INR on them, and if the INR is less than 1.7, we can still give tenecteplase or alteplase. But any other anticoagulant, if they've had any of it within the 48 hours, it knocks them out for getting tenecteplase. They're automatically no longer a candidate for it. Again, last known normal has to be less than 4.5 hours. Blood sugar has to be normalized because hypoglycemia, low blood sugar, actually mimics stroke. And then blood pressure, that blood pressure has to be less than 185 over 110 in order to initiate the medication. After we give it, then it drops down by 5 points systolic and 5 points diastolic, so it decreases down to 180 over 105. The patient needs or should have a measurable neurological defect like right arm weakness, speech difficulty, stuff like that. They need to have a negative head CT, so we like really boring head CTs here at this point. And then again, just know that only about 4% of all patients actually qualify to even get this medication in the first place. So let's go through mixing and dosing tenecteplase. For those of you that are not responding to the code stroke, but rather are the primary nurse calling the code stroke, you don't necessarily need to know how to mix it, but you will have to be the second eyes in verifying the dose. All right, so you'll be the second nurse sign off on the dose of tenecteplase to give. So again, tenecteplase is 0.25 milligrams per kilogram. Is consent, written consent, required for this medication? The answer is no. We do not need to have the patient sign a consent form to receive this medication. It is considered best practice to receive this medication by the American Heart Association guidelines. So although there should be a discussion between the provider and the patient about the risks of the medication, the verbal consent to the medication can be documented in the chart by the provider. However, if you have a situation where the patient is unable to consent and we are unable to get a hold of the family, then again, American Heart Association would recommend giving the medication as long as that patient fits criteria, as opposed to withholding that medication. So in order to give this medication, again, it's a weight-based drug, so we need to establish the patient weight. So we need to do everything we possibly can to get an accurate patient weight. If they're already upstairs or if they're in a trauma bed, we can get a bed weight on them. Um, do everything we possibly can to get an accurate scaled weight. All right. If we cannot get a weight by a scale for this patient, then we go into our other options, right? If the patient is awake, alert and oriented, we can ask the patient how much they weigh. We can look into any recent provider visits. The little trick that somebody taught me was if you go into the weight area of the flow sheet and type in 999, it'll pull up like a little BPA and say, are you sure the patient weighs this? Because on this date, the patient weighed this. And that gives you the most recent documented weight that's in the chart, okay? However, if all else fails, if we can't get a scale weight, we can't get a stated weight, we can't get a chart weight, then the last thing that we can do is do a two-nurse estimation of that patient's weight. Now, that needs to be documented. We need to make sure that we are documenting, Alicia RN and Tammy RN agree this patient weighs 145. Once we put that in, then we would document that in the flow sheet, and then the patient would be dosed based off of that estimation. All right. The medication is a high-risk drug. So there does need to be a two-nurse sign-off in addition to the two-nurse verification of weight, estimation weight. So what does it look like? There's a little box. It's housed, tenecteplase is housed in ED. It's housed in the CT scanner, done in the CT scanner room. And so it comes out of a little box that has two vials. One vial is sterile water. One vial is the powder version of the tenecteplase, and there is a syringe with a needle already in there. So what you would do is you actually take out the syringe, unwrap it, inject it, or go into the sterile water, pull out 10 milliliters of sterile water, and then you inject it into the powdered tenecteplase. Once it's injected, then you take out the syringe, you roll the tenecteplase vial back and forth. You do not shake it because it will create bubbles that will not go away. You roll the vial until all the powdered version of the tenecteplase is dissolved. And then once you have it dissolved, then you would withdraw the dose based on the 0.25 milligrams per kilogram. Maximum dose, again, is 25 milligrams, and that equals 5 milliliters. So we're putting in 10 milliliters of sterile water. We can only take out the maximum of 5. All right? Again, before we actually administer the tenecteplase, we need to have a complete NIHSS prior to, but less than 15 minutes before tenecteplase. So if our tenecteplase is going to be like, let's say 9 o'clock, right? Then between 8:45 and 9 o'clock, I need an NIHSS with a vital. And then at 9 o'clock, when we give tenecteplase, we need another full set of vitals and full NIHSS. From there on, you can move into your modified NIHSS checks. And just to be clear, for every neuro check, there needs to have a vitals documented at the same time, please, same time. We cannot set the vitals machine to go off every 15 minutes and then our neuro check comes 5 or 7 minutes later. It doesn't work like that. We need to verify whether the change in the blood pressure is directly changing their neuro checks, right? So we need to make sure that the blood pressure and the neuro checks are done at the same time. I know it can be tough because I know our vitals machine, when you set it, it tends to go to 15-minute, 30-minute, 45-minute, top of the hour. All right? It doesn't go from 15 minutes from the time you set it. So if you're giving tenecteplase at, let's say, 07, right, then your next neurocheck and blood pressure would be in 15 minutes. However, that's always going to be offset. The easy way to kind of correct that is to do a one-time early neuro check and blood pressure. So let's say again, you give it at 07, then you can do an early one at quarter after, and that resets all the other neuro checks to quarter after, 30, 45, top of the hour. All right. That is the easy way to be able to stay on track and make sure that your blood pressure, your vitals, and your neuro checks are done at the same exact time. All right. This is your thrombolytic therapy worksheet. If they're transferring from an outside facility, the outside facility, like our sister hospitals, should be sending this sheet with the patient. This sheet has the front end of it is for EMS. It helps them to stay on track of when they need to document neuro checks for these patients in their report. All right. And then the back of it needs to be documented for each thrombolytic therapy patient. If they come from an outside hospital and they've received it at the outside hospital, then we just continue on from the time the patient arrives to the end of the sheet. We don't have to restart. But again, I'm going to stress that before we give the tenecteplase, before we push that bolus, even if it's 1 minute before, you do your NIHSS and your vitals, full NIHSS vitals. Again, at the time you give the medication, NIHSS vitals, and then move into your modified, okay? Using the sheet keeps you on track. Please make sure that we're using the sheet and that we're handing it off to the next nurse or to the next unit. Blood pressure control following thrombolytic therapy administration. So blood pressure should stay below 180 over 105. It helps decrease the risk of having a hemorrhagic transformation, and we want to be able to control that blood pressure with a nice nicardipine drip. If we're giving IV boluses or IV pushes to try to bring that blood pressure down, then essentially you're going to let that blood pressure spike and drop and spike and drop, and it puts the patient at a higher risk for hemorrhagic transformation. So let's just control that blood pressure by using nicardipine, a nice steady drip. So what do we watch out for patients that have received alteplase or received tenecteplase? So essentially the same thing, right? It's a clot buster. It puts them at a higher risk of bleeding. So you're going to want to watch out for any signs or symptoms of an intracerebral hemorrhage, a new headache, worsening neuro symptoms, right? It's not uncommon to have a patient to kind of ooze or start to bleed in areas such as gums, or maybe like if there was a Foley inserted, they might have a little bit of trauma from the Foley. Nosebleeds, I've seen nosebleeds, I've seen IV sites start to bleed. That does not want us to stop. If they're receiving an infusion of alteplase from an outside hospital, we don't want to stop it just from an IV site bleeding. If we can put pressure on the area that's bleeding, then we're going to continue with the medication. We worry about areas that we cannot put pressure on or we cannot stop that bleeding, such as intracerebral, such as GI bleeding, right? We want to watch out for that. Also, patients that receive this medication have a higher risk of having swelling of the lips and tongue. So angioedema. You're going to want to watch out for angioedema, especially if they're on any type of pill medication. You're also going to want to watch out for any type of anaphylactic reaction. And also those that receive this medication have a higher risk of creating a cholesterol embolization. So when do we notify a physician immediately? We notify them anytime there's serious bleeding that occurs or development of angioedema. We do it anytime there is acute onset of hypertension, nausea, vomiting, seizures, or worsening neurologic examination, or decrease in or loss of consciousness. Treatment options, mechanical thrombectomy, you're going to remove blood clot from the brain. So we put in a wire, we deploy a stent, and it grabs the blood clot and yanks it out of the brain. Preparing the patient for an emergent mechanical thrombectomy, it's going to be the same prep as an emergent cath lab. You're going to have all the clothes off, jewelry off, oral fixtures removed, groins clipped. You're going to have a Foley if able and a second IV if able. So mechanical thrombectomy, this is a picture of what it would look like. The stent actually presses the blood clot against the vessel, and the blood clot becomes enmeshed in that stent, and it's retracted out of the brain. This is an image of a thrombectomy. So this is here, the clot's sitting right here. You can see there's no flow coming through here, and this would be after the flow is coming through. What do we do in a code stroke? So first of all, signs and symptoms of a stroke would be balance change, vision change, facial weakness, arm weakness, speech changes, and, T is for time, hurry up, please. To call a code stroke, you're going to dial 971-2323. You're going to tell the operator to call a code stroke and the patient's room number, and you're going to start prepping for the stroke team to arrive, and you're going to follow the flow chart. The primary nurse does go with the acute stroke team for imaging and acts as a second nurse to sign off if tenecteplase is administered. This inpatient code stroke flow chart is housed in your stroke binder, your unit stroke binder, so you can grab that and reference that as you have code strokes coming through. You have a role delineation. It marks through what the role is for the primary nurse, as well as the rapid response or ICU nurse. This is your inpatient code stroke kind of checklist, if you will. This will help you maintain kind of a formatted code stroke. Roles and responsibilities is to be at bedside within 15 minutes. Our secondary goal really is to be at bedside within 5 minutes. We need to obtain the items needed to decide whether we're going to give tenecteplase or whether we are going to do a thrombectomy. We need to start the CT scanner within 20 minutes from the time the code stroke arrived. And then we need to give tenecteplase, if we're giving it, under 45 minutes. To prepare for emergent endovascular therapy, we need to have a code stroke, or the time the patient arrived at the hospital to the time the groin was punctured, in less than 90 minutes. Know that your personal risk factors for a stroke. Know that the number one modifiable risk factor is high blood pressure. For non-modifiable risk factor, once you've had a stroke or a TIA or a heart attack, you're at a higher risk of having another one. All right, what mimics a stroke, right? Conditions that mimic a stroke. You have generalized seizure, so tonic-clonic seizure. You can have a gaze preference with it. Oftentimes when they're seizing, the gaze preference is on the same side as their weakness. When they're in a post-ictal state, they may have a gaze preference that's on the opposite side of the weakness. And then they could potentially have also, like any type of an injury to the lip or tongue or cheek from biting. They could have loss of bowel or bladder. And when they're in this post-ictal state, they can have weakness on one side of the body as well. Brain tumor, you'll have imaging that'll have a brain tumor with fingers of fluid that are pressing against the cortex of the brain, and that compression creates weakness in that side of the body. You can have a hemiplegic migraine. So this migraine actually mimics a stroke because it's similar to like an aura of a seizure. It's an aura of migraine. So you can even have a patient that has a GFAS score of 5. Bell's palsy, this patient usually has had a previous virus, and that virus has actually palsied that facial nerve. So a central injury, like a stroke, central palsy, is down below, whereas a peripheral nerve palsy is the entire half of the face. Hypo and hyperglycemia also lead to altered consciousness or hemiparesis. And some additional stroke mimics are listed here as well. We see a lot of metabolic encephalopathy, and we see credescence of previous stroke symptoms. So if the patient has had a stroke previously and now they have a urinary tract infection, it kind of reactivates the weakness that they've had from the previous stroke. And oftentimes it's not another stroke, it's just recrudescence of the previous stroke symptoms. Feel free to do a case review if you'd like. You can go onto YouTube and enter in the address below, and you can watch this. It's a story about a 34-year-old female that was having a very large stroke. It shows her assessment prior to, her procedure, and her assessment after she received a thrombectomy. If you have any questions at all, please feel free to reach out to your stroke team, myself. You can reach out to charge nurse. If I would rather you reach out and ask questions to get clarification than trying to figure it out yourself. Again, I'm a resource here for you, so feel free to reach out. All right? Thank you so much, you guys. Have a fantastic day.